Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the last week of April, April 26th of 2022 as I record this. And as I speak, the world is up to a cumulative total of COVID-19 cases numbering 510.6 million cases with over 6.2 million deaths. Here in the United States, we are just over 81 million total cases since the start of the pandemic, with almost 992,000 deaths. So we're approaching that very unfortunate and grim milestone of almost 1 million deaths in this country alone. In kids, from the AAP report dated April 21st, we are up to 12.9, actually over 12.9 million total cases, which is 19% of the cumulative total. That comes out to just over 17,000 cases per 100,000 children. Again, a more important milestone marker, I think, is the percentage of total cases that occurs on a weekly basis. So for the week ending in May, it's not May yet, in April 21st, we were just over 16.3% total cases were pediatric in origin. And in Arizona, we are at 428,624 total cases, or 21.2% of total cases that are kids from the start of the pandemic. Our rate comes out to 23,312 per 100,000 children. Important fact to note about the AAP report, and this is well described in their initial description. Many states, not yet including Arizona, but many other states have stopped daily recording of COVID cases for children. In fact, have stopped recording daily cases, period, as well as other frequencies of testing and availability of screening tests. All of these have diminished. So the data needs to be taken with a large grain of salt. Arizona still continues to report, but again, our testing abilities, I think, have decreased significantly, with a decrease in at-home COVID tests and certainly a decrease in the ability to capture those at-home COVID test results. So basically, we're capturing those children and adults for other parts of the pandemic who are presenting to their doctor's offices with a publicly reported result or are getting tested through various pharmacies and other testing structures. The other sort of ominous milestone, at least in kids, is the mortality rate, or number of deaths, actually. The rate, thankfully, is incredibly low. It's less than 0.1% in most parts of this country. It's up to 0.3% mortality rate in other parts of the world. But in Arizona, we stand at a total of 66 pediatric deaths that are associated with COVID-19. Again, some directly attributable to the virus infection itself and sepsis related to that, and others are related to the state of the pandemic. Arizona has dropped to number 3 in the country in terms of total number of children deaths, following California, that's at 70, and Texas, that's at 127. And again, this is not the rate, this is just the total number. And both California and Texas will have far greater numbers of children, so that the rate per 100,000, fortunately, Arizona is probably at the top. So it's been a little while since we last recorded. We had a couple trips away and some other focuses, or foci, I should say, in terms of other infectious diseases, which is actually the subject of one of the questions today. But let's hit the COVID questions first. The first one is, can I comment on the end of the COVID-19 emergency declaration in Arizona? And I think almost by extension in this country. Keep in mind, of course, that emergency declarations are largely a political tool, not necessarily a public health tool, although, of course, we all agree they should be. And I think is it against many public health officials' better advice and better judgment that we back off on the emergency preparedness declaration at this time. Indeed, it is true that we've had multiple weeks in a row of decreasing case counts and decreasing death rates and decreasing hospitalizations, and all of that, of course, is fantastic and quite good. But yet there are parts of this country, especially currently the Northeast and Chicago, as it turns out, that are having an increase in numbers. And there's every likelihood that that will occur here in Arizona as well. This increase is due, of course, to the BA2 subvariant of Omicron, which is more infectious than BA1, what we just finished our last surge with. Not a significant increase in virulence or hospitalizations and thankfully in death rates, but certainly there are higher numbers of cases. And so a declaration, the emergency declaration coming off, largely is just a way of sort of marshaling resources and stopping the bleeding of dollars to support the public health response to try and keep our citizens safe. You can probably tell my bias here. I think it's a bad idea, and I think it is premature in any part of the country, and certainly in Arizona, to come away from that declaration. What it really means, however, in terms of preparedness, is not much more than an official recognition and perhaps a decrease in overt funding. In terms of county health departments and the Arizona Department of Health Services, absolutely all these entities continue to view COVID as a clear and present danger right now and a true threat, along with other viruses, and continue to marshal such resources as are available to support contact investigation, et cetera, and so forth. But to be quite honest, the dollars for contact tracing have gone away, and the ability to provide federally funded and even certainly state funded testing kits and testing strategies has gone away. So what do we really experience from the decrease or the end of the emergency declaration is a decrease in the ability to pick up on the next surge when it occurs or to accurately track the current numbers. That said, where are we at? Do we truly have a risk of another surge? And I think it is very likely we will continue to have times of increase followed by times of decrease. This may correlate to yet ongoing viral mutation and new variants coming through. I do believe, however, as do many, that the Omicron variants, BA1, BA2, and all the others out there, do represent sort of the next stage in this pandemic of ours, which is getting to the point where through combination of natural immunity, vaccine immunity, and just the virus virulence itself, that the COVID-19 is becoming more and more a survivable illness, especially for those who are vaccinated and boosted, but even so for those who have partial or no immunity. So what is the impact of not tracking those numbers? What is the impact of coming out from behind the masks on airplanes, for example, and public transportation? Yeah, there's going to be increased numbers, absolutely, for sure, 100%. But what that truly means in terms of burden on healthcare and deleterious effect on children's health, I think it remains to be seen. It remains to be seen. And certainly there are, as we try to reel back from the ropes with the current COVID-19 pandemic, there are many clear and present dangers affecting our children and others as well that also need our attention. So that this may be yet another sign, in this case a political one, that we're moving away from pandemic status and more to endemic status, although that remains absolutely an epidemiologic decision, certainly not a political one. Oof. All right, enough on that subject. Question 2, probably in terms of what I just discussed, how can we best equip providers and healthcare staff in terms of COVID-19 testing, diagnosis, treatment, and helping our patients? And I think, again, we are in part hindered by the lack of funds going forward for the free testing, and also just in terms of the availability of at-home tests, in-office tests, etc. This is, I think, going to become more of the influenza model and perhaps the other respiratory virus model, where testing is available. It will be for a charge, and hopefully insurance will cover part of the charge. Certainly we will be less readily able to make these diagnoses in the office setting, hopefully still readily able to make diagnoses in the urgent and emergent care centers, and certainly in hospitals. But I would certainly not intend or wish for us to escalate care or transition care to the urgent cares and EDs in hospitals when we can still clinically make many of our diagnoses and support our patients. In terms of the availability of antiviral treatments, as of actually today, as I share this with you, the Biden administration is taking yet more steps to increase the throughput and availability of such antivirals as Paxlovid, the Pfizer combination antiviral, because of its ability to prevent escalation to severe disease and protect those individuals who are going to become increasingly infected with risk for severe disease. That, of course, includes children. Now, Paxlovid is still for the sort of age 12 and up, and hopefully that indication will continue to be examined and lowered to younger children who also have immune dysfunction, immune suppression. But I think we can anticipate over the coming months an increasing availability and increasing possibility of prescribing important either prophylactic and or preventative steps, medications, monoclonal antibody products, Evishield, etc., for our children, certainly who are under age 18, and hopefully increasingly for our children under age 12. Yes, I do believe that's going to happen. The timing, however, I think is up for grabs. So too, the continued most important part, which is prevention, prevention, prevention. And as we all well know, we're still awaiting data from data from Pfizer and Moderna to be considered by the FDA to get an indication for a valuable and viable vaccine product for children under age 5. April was intended to be the month that Pfizer would go back to the FDA with its requested data for children ages 6 months to 2 years and from 2 years up through 4 years. But as yet, we've not seen any official release of that data. Moderna has gone to the FDA with its preliminary data for children under age 5, and as yet, that data has not yet been considered. Similarly, both vaccine manufacturers have gone to the FDA in a bid to get booster doses approved for younger age groups. For Pfizer, that would mean a booster dose under age 12 going down to age 5. And for Moderna, age 18, and actually to get an indication to even administer dosing down to 5. So that would be a great step forward to have two vaccine products, both of which have stated and proven efficacy. And certainly to then, after initial vaccination, to be approved for boosters for kids under 12, that would be fantastic. It appears that the FDA is convening its advisory committee to examine the safety, efficacy, and indication for a booster dose for that age group by or around the first part of June. So yeah, you heard me right, June. So we're another easily 5-6 weeks away from even hearing about the decision, and then to roll that out is going to take still some time further. As this virus has shown, a lot can happen in a month and a half. Hopefully right now we're in a quiet resting period waiting for the next steps, and we have at least the slight luxury of time for most individuals to wait for that indication. So fingers are crossed. Back to the question, how can we best equip our providers? I think through continued advocacy, which the AAP is absolutely conducting at the federal and also state levels to increase throughput for those preventative steps, throughput for the treatment steps, and to continue to support availability of testing kits, testing strategies, and just continued awareness that, as good as things may seem right now, we're not through this yet. And we are likely not going to be through this for the foreseeable future. Hopefully what we are and will experience is going to be more manageable, but only if we keep our eyes open and our hands ready to do good work. All right, next question is actually on a topic unrelated to COVID, and this sort of highlights the fact that while we've been hyper-focused on COVID-19, there are other epidemics bordering on pandemics which are occurring right under our eyes. A very huge one, of course, is the epidemic, in this country at least, of mental health disorders of children, adolescents, young adults, and adults who are contemplating suicidal ideation, and then that the rates of incomplete and unfortunately completed suicide have skyrocketed 30 to 40% in some parts of the country. Certainly the diagnoses of depression, anxiety, SI, other mental health disorders have all skyrocketed across this country and truly actually through the entire world. So that, of course, continues, and our colleagues who practice counseling and psychotherapy and psychiatry are buried, and all we can do is hope and pray that everyone takes a deep breath and gets through this while continuing to screen in the routine office visit, harnessing the private practice, the community practice, the site of primary care as medical home to re-engage with our students get them under our assessment, get them under our screening tools, and allow us to hopefully pick up and then save those children that are actively contemplating suicide. So that is a big one. The question actually asks about the rise of syphilis cases among newborns in Arizona. And yeah, that is absolutely of significant concern as well. For those who have not heard me speak on this before and or have not seen the public health releases, Arizona is number 2 in the country for rates of congenital syphilis based on data through 2020, and we only got significantly worse in 2021 and so far to date in 2022. So we are in the middle of an explosive epidemic of syphilis, primary, secondary, latent, and congenital syphilis in Arizona, far more so than many other parts of the country, although the rest of the states is not doing so well either. So what this means then is that many of our mothers coming in to deliver having either unrecognized syphilis and far more frequently not completely treated syphilis. In my personal practice experience, a majority of the babies that I have treated, and it's already been 7 since the start of 2022 for congenital syphilis, a majority of these babies are being born to mothers who are very much on the fringes of society, are under-resourced, outcasts, suffering from polypharmacy abuse, homelessness, etc. So this is an incredibly at-risk maternal population with multiple risk factors, and of course, therefore, very significantly affected ability to access healthcare delivery and preventative healthcare steps. So these are the women who, if they are being treated for syphilis, it is almost by pure fortune that they may have been screened and diagnosed while incarcerated and received the first of their doses, but then were unable to complete the second and third doses. Or they did find their way to a prenatal care visit, or to a primary care practice, or to an obstetrician, or to an emergency department, or someplace like that, where they also were diagnosed and received a first dose. But the ability to complete the treatment for syphilis, unfortunately, has been sorely lacking. So many of the moms come in then with titers that are positive, a history of incomplete treatment for syphilis, and a baby with a positive RPR titer that of course then must be treated for likely exposure to syphilis. Fortunately, a majority of the babies treated so far in Arizona have not had symptomatic congenital syphilis. So very few cases of neurosyphilis, syphilitic hepatitis, syphilitic periostitis, osteitis, and that's a very good thing. But they still need to be picked up and treated so they do not develop those. So yes, we are absolutely in a major cause for concern with our rates of syphilis. And as I now have, fortunately, the ability to consult with and advise my local county health department, Pima County, we are treating this as indeed a crisis. And basically every single case of congenital syphilis is a preventable illness. There's no reason that we cannot find these mothers, diagnose them, and provide treatment. And then more importantly, or I should say as importantly, is discover their sex partners and identify and treat those individuals as well. So continued escalation of attempts at the health department levels to find, diagnose, and treat said individuals. But it's currently an uphill struggle because many of these, again, are on the fringes of society and not accessing healthcare delivery through routine channels. So your thoughts and input of how to try and navigate that particularly big challenge are quite welcome, I am sure, by all health departments, and certainly the ability to be on the lookout for positive RPRs in babies, especially those born to mothers whose prenatal healthcare history is somewhat challenging. Along with the rise in congenital syphilis, we are also seeing rises in HIV transmission, gonorrhea, chlamydia cases. So pretty much name your sexually transmitted infection, and unfortunately, and in direct parallel with those who are continually marginalized from society, there are increases across the board. What else is out there? I think we all know this has been already a significant respiratory virus season, and that continues. Influenza A and some parts of the state, influenza B, has made an incredibly large comeback. There are whole schools that are now being afflicted with epidemics and are going through testing and various isolation procedures. So too, our dear friends rhinovirus, enterovirus, human metapneumovirus, adenovirus, etc. All those are out there as well. And I need to say this, hopefully for everyone who has ears to listen, there is also a very concerning new development in children under age 10 and actually quite significantly under age 6 years, presenting with a viral prodrome, typically gastrointestinal nature, followed by fulminant liver failure. 9 cases now reported from the state of Alabama. Other states around the country reporting in with several, California, Texas, some on the Northeast. Arizona may have its first highly probable case as well that I had the ability to participate in. These are children who will have perhaps a vomiting or diarrheal illness accompanying with some respiratory symptoms, followed several days later by onset of scleroicterus and jaundice. And when one does the labs, they're found to already be in liver failure. Transaminases in the thousands, elevated bilirubins, of course, with the jaundice, and evidence of synthetic dysfunction in terms of coagulation cascade difficulties, hypoalbuminemia, etc. The experience in Alabama and the rest of this country is actually following that, also being reported in the United Kingdom, in parts of the European Union, including Spain, and in Israel, where there are now almost 200 cases reported in the world's literature presenting in a very similar way, that prodrome followed by liver failure that I just described. The virus that's being identified as the likely culprit is adenovirus type 41, and there are a couple subvariants there as well, which I won't bore you with. So in that setting of a child with a viral illness, which may be gastrointestinal and perhaps respiratory, followed with early evidence of liver failure, do send PCR-based testing, most often from the respiratory specimens like the nasopharyngeal swab and or GI pathogen swabs. Do send PCR testing for adenovirus if at all possible, and contact your local pediatric infectious disease provider if possible, and or certainly your local county health department. So the Arizona Department of Health Services is eager to track any suspect cases, so don't be a stranger to them if you have a possible suspect case. So GI presentation with some respiratory illness, sometimes a viral prodrome, followed by evidence of liver failure, especially jaundice. Don't hesitate. PCR test for adenovirus. Contact your reference providers and contact the county and potentially state health department. So with that, folks, thank you again for listening to ID Talk. Arizona AAP members can submit questions for future episodes to covid@azaap.org. The Arizona AAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, hang in there, keep breathing, do the right things I know you are all doing, and thank you so much for your service in that regard, and for helping protect the health of our kids. Be well.